Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of Halloween/November 1st. It is, in fact, November 1st as I share this with you. And a couple questions to answer today from our chapter's members. And also, I think, an update on just general infectious diseases and what's happening out there. Perhaps the biggest first question, and related to COVID, is are we expecting a triple-demic of COVID-19, influenza, and RSV? And along the lines, what are the updates in all three of those individually? The short, quick answer is yes, we're expecting a triple-demic, although it's a little bit clunky off the tongue. We'll have to come up with a better descriptor, such as we had flu-rona last year. So yes, we are already seeing a surge of RSV at this particular moment. It is early, and also it is occurring in older patients. And so whereas the typical RSV bronchiolitis is in our infants to younger toddlers, we're seeing children up into ages 4, 5, 6, 7 years of age, and even some older with co-infection with other things that are coming in sick. So very similar to what we have just been experiencing and still are experiencing with rhino/enterovirus. We're seeing a slightly older age population, not necessarily children with reactive airway disease or respiratory wheezing tendencies, but who are getting RSV and coming in with sort of fuller-fledged bronchiolitis. So oxygen requirements, multilobar pneumonias, respiratory failure. Some are benefiting from bronchodilators. Some are benefiting from asthma management, but yet others are requiring non-invasive ventilation and oxygen support. And importantly, they are requiring hospitalization. So I imagine all of you are experiencing, as we are at my local hospital, quite a burden of respiratory illness, which has just continued and is getting worse as RSV now kicks in. So that's already here, and every expectation is that RSV will continue to be a challenge for us through the winter months and even on into spring. Influenza, yes, we are starting to see influenza A and B cases, although influenza A so far has been the most prominent. That actually started quite some time ago, but the numbers are starting to increase as we speak, and the indications are that influenza will be a bad season based on experience in Australia, New Zealand, parts of Asia, where they have been having a significant numbers of influenza A cases. So that part is absolutely on the way, and again, supporting influenza vaccination, very important this year, especially as we anticipate having yet more cases coming out of the woodwork. And then our dear old friend COVID-19, which started this podcast and will continue to fuel this podcast for still yet quite some time. COVID-19 is absolutely still present, and there are children hospitalized as we speak with SARS-CoV-2 infection. What is new, I suppose, or emerging, are yet another host of variants or subvariants. We have been dealing with the subvariant, Omicron subvariant BA5, to a lesser extent BA4, and now you get a whole new collection of alphabet soup, which is the BQ.1 and the BQ.1.1, and if that wasn't enough, the BQ.1.1.01. At least it's being somewhat similar in its numbering. The BQ.1.1 is perhaps the most prominent of those Omicron subvariants, currently accounting for 13% of new cases of COVID-19 in the United States, and certainly those three subvariants have been demonstrated and confirmed here in Arizona by our viral typing, which is performed through TGen and through ATSU. There are also the XBB.1s and the XBB.3s, all of which are also still subvariants of Omicron. And so it seems that Omicron is with us to stay, likely through the ongoing pandemic into endemic into epidemic phase. And so these are mutations occurring within the construct of the Omicron variant itself, and each mutation typically involving a component of the spike protein or some other antigenicity of the virus is modifying the viruses, the subvariants I should say, become yet more infectious. So that's an important distinction. So yes, there are currently and will continue to be more COVID-19 infections due to these emerging subvariants of Omicron, the BQ.1111s and the XBBs. So those are here for sure, and they'll be causing more infections. However, and this is important, there is not so far a significant change in the virulence, clinical appearance, hospitalization rate, death rate, etc., and so forth. This also is based on data coming to us from other parts of the world that have previously experienced an early surge with these new subvariants, and yet their hospitalization rates and thankfully the case fatality rates have remained fairly flat, plateaued. So the diseases or the subvariants are more infectious, but they're not yet conveying higher virulence. So today, as we speak, our experience in pediatrics with COVID-19 in the United States and here in Arizona still continues to be primarily an upper respiratory tract infection, so the so-called COVID croup, and that is still absolutely true. Some patients develop a severe lower respiratory tract disease, typically, however, in combination with other viruses. So, are we expecting a triple-demic of COVID-19, flu, RSV? Yep. Yes, we are already here, and I think we can anticipate a fair number of children requiring advanced care and hospitalization with at least two of those three named viruses causing their disease. Now, perhaps adding a fourth, that still yet being rhino/enterovirus, which also is still conveying a fair amount of disease with morbidity and hospitalizations. So there you go. We got those. The COVID-19 is absolutely still here to stay, continues to be fairly adept at evading immune protection by the original monovalent vaccines. However, continued emerging evidence with the bivalent vaccines, again, as talked about last time, those are available for kids ages 5 and up as boosters, both from Pfizer and Moderna. But the bivalent vaccines are showing increased protection even against the new subvariants of Omicron, so the BQs and the XBBs. So fingers crossed that continues to be the case, and as always, every week is kind of a new week, and we'll have to play it by ear and see what happens next week or 2 weeks from now. So that's question 1 from our chapter's members for this week. Question 2 is a wonderful departure from COVID and some of the other things we've talked about, and it has to do with eczema herpeticum. Yes, eczema herpeticum, which I imagine many of you have experienced in your practices and patients, although maybe not necessarily everybody. Eczema herpeticum, or sometimes known as dermatitis herpetiformis as a synonym, although I'm sure some of our dermatology colleagues who will quibble with that, and I apologize for that, but eczema herpeticum occurs in a patient with known atopic dermatitis, so eczema, if you will, regardless of their level of severity or disease control, who then gets infection with herpes simplex virus, typically HSV type 1, which, if you recall from our medical student learning, is the one most often associated with orolabial or gingivostomatitis type disease. Increasingly, though, HSV1 is accounting for an increasing amount of genital herpes as well, possibly due to autoinoculation and then continued propagation via protected intercourse and close genital contact. So regardless of mechanism of exposure, HSV1 and potentially HSV2, if acquired causing cutaneous disease in a patient with atopic dermatitis, has the potential to trigger that atopic dermatitis into a severe flare, which then in a vicious cycle triggers a worse outcome with the cutaneous herpes. They basically feed off each other with sort of this immunologic co-recognition, making worse and worse disease. So the typical patient with eczema herpeticum will come to you not just with a small little patch of cutaneous herpes, such as we see perhaps in our wrestlers and football players, etc., but they'll come in with extensive cutaneous disease head to toe in all the areas of normal distribution for atopic dermatitis plus every place else. So it is really quite nasty and unfortunately can be fatal. So these patients can be incredibly sick and they can have overwhelming herpetic disease, especially if they then become viremic from their either autoinoculation, reinfection, or infection in the first place. So the questioner asks, and this is an incredibly important question, what are the guidelines for eczema herpeticum? In particular, how do we know when to admit a patient? How do we know when to use treatment or IV versus oral therapy? I mean, basically, how do we work up and manage these patients? So the first part of the answer is being able to recognize the patient in the first place. And this is important because eczema herpeticum has a fairly typical appearance, which if you haven't seen it clinically, I urge you to look at pictures through CDC, through our various dermatology colleagues, or through CDC, for example. Basically, eczema herpeticum lesions are punched out lesions such as you might see with a somewhat advanced chickenpox or cutaneous herpes infection. So starting with the vesicle and then eroding into that erythematous tender ulcerative lesion, punched out lesion, with in addition the sort of crusty scaliness of an eczema flare. Some patients, as they have a very active disease, will also have vesicles which are quite both that sort of waxy whitish to yellow appearance, some of which are becoming hemorrhagic in various stages, also in the middle of a patch of denuded eczematous appearing skin, all with that overlying sort of seborrheic component. So it can really appear quite nasty, but the key is to look for presence of vesicles or those punched out ulcerative lesions. That is the appearance of eczema herpeticum. So step 1 in diagnosis, clinical recognition. Step 2, if one is on the fence or is like, it could be herpes, it could be something else, is to perform a lesion swab. So the root or the base of the lesion, not the top of the vesicle if that's what you have, but actually getting tissue, which is going to be painful, but swab the base of the lesion for tissue, setting it for herpes PCR if your either laboratory or clinic setting has that capability, or for fluorescent antibody stain for herpes simplex virus. We've gotten away from the zinc smear, which is what I think many of us learned from our boards, only because it is not as sensitive or specific as are the fluorescent antibody stains, and very much far less sensitive specific than are the PCR-based tests. So looking for evidence of herpes to confirm the diagnosis. However, a clinical diagnosis is more than adequate. Keep in mind, there is a differential diagnosis for eczema herpeticum, and that can include actually impetiginized or impetigo, overlying eczema, or classic hand, foot, and mouth disease, or our dear friend Coxsackie virus. And there is actually a form of eczema coxsackium, which would be Coxsackie virus, hand, foot, mouth disease, triggering an eczema flare very similar to what I just described with herpes. The difference there, however, will be not seeing vesicles per se in the dermatitis plaque fields, and instead seeing that sort of more of a pustular or hemorrhagic pustular component. And then, unfortunately, even just a horrible eczema flare, especially in younger children and infants, is and can look quite pustular as well. So pustular eczema is a nasty appearance that looks for a whole lot of worlds like bacterial or herpes or a viral infection, but is truly a sterile inflammatory process. So step 2 of the diagnosis is to consider the differential diagnoses. Step 3 then, if one is testing or not, is to consider empiric management. And here the protocols for management, there isn't a standing standard of care, but if one searches the literature, which I have, and looks at recommendations from professional dermatology societies, from the NIH, CDC, basically you're looking for mild versus severe disease. Mild would be that patient with 1 or 2 plaques of sort of eczematous skin with herpetic appearing lesions involved with that, not involving perioral, periocular, or perimucosal surfaces. So, for example, the child who comes in with perhaps herpetic appearing eczema lesions in the antecubital fossa, in the flexure creases, sort of typical for a classic atopic dermatitis, and only there, who is afebrile, not in severe pain, smiling, eating, drinking, that would be mild disease. Those are patients who can be treated with oral acyclovir or valacyclovir. Valacyclovir is the prodrug of acyclovir, has far improved absorption and thus drug delivery, different dosing regimens for those, but in general, mild disease can be treated with oral acyclovir, typically for 7 up to 21 days. The key is to treat until the lesions have crusted over, the flare of the eczematous component is fading, and then add on an additional 3 to 5 days to make sure that the virus is well and truly sort of subdued, if you will. All other patients, so far more extensive spread, patients with any sort of mucosal or perimucosal involvement, patients who are highly febrile, patients who are starting to have a decrease in their oral intake, all of those patients absolutely deserve hospitalization and intravenous acyclovir at 30 milligrams per kilogram per day divided Q8 hours. Typical standard dosing for all but the very youngest neonates with herpes with IV acyclovir. Keep in mind that patients who have eczema herpeticum may also have an impetiginous component, so may also have bacterial superinfection, typically with Methicillin susceptible Staph aureus and group A strep. So you may be adding perhaps a first-generation cephalosporin or some other antibiotic coverage in those patients should they also have an impetiginous component, that sort of honey-crusted or golden-crusted appearance overlying some of the lesions. The chief things to keep in mind, though, are that if the patient has involvement involving their eyes, absolutely request a consultation or at least in some sort of involvement from pediatric ophthalmology, including a fluorescein in the eyes, looking for the pitting or the dermatitis or, the conjunctivitis with pitting of the conjunctive itself, because those are patients who might also benefit from topical acyclovir. So eczema herpeticum is and can be a very big deal. Sometimes the eczema has been triggered into a long-standing flare that, as we might with other patients with an eczema flare, need to consider a steroid involvement. As you can imagine, as with any other child with a severe eczema flare, topical steroids, while useful in some cases, are going to be kind of painful. So there are the occasional patients with severe eczema herpeticum who also need some sort of anti-inflammatory management to bring the eczema flare component under control. And here, and it's counterintuitive, and I shudder to even say this, but sometimes those patients require systemic steroids. Be very careful in doing that and absolutely involve a dermatologist if at all possible, and or infectious diseases, because of course using systemic steroids, even oral prednisone or prednisolone, has great potential to pour gasoline on the herpes fire and allow that to take off like a shot. So if one is considering some sort of steroid involvement for an eczema, be very sure that there is not herpes, and if there is, co-treat with IV acyclovir at the same time. So I guess that the picture I wish to paint is handle eczema herpeticum and the concern for that with great degree of caution. Do not hesitate to reach out for help, including colleagues who may have seen such cases, just to help you decide how best to proceed, and have a very low threshold to start acyclovir, either oral or IV, if needs be, as part of your management. And keep in mind the risk of superinfection. Okay, so those are the questions we have for this week. A couple other brief updates, just sort of ongoing as we have been. Monkeypox, thank heavens, continues to be largely not active in the United States now, certainly in Arizona. Yes, there are continued sporadic cases, principally, however, in the high-risk population, being men who identify as gay, bisexual, or transsexual, and or heterosexual partners of such index patients. Very few pediatric patients reported in the country, and none that I have personally managed or been made aware of. Although if in Arizona you are aware of a patient and wish to at least share that fact with us, I'll happily mention that on the next podcast. So monkeypox, by and large, is on the way out, thank heavens, part due to a somewhat effective vaccine campaign with the Jynneos vaccine, but I think also very much in part, and credit where credit is due, to behavioral changes and modifications by at-risk populations in this country and elsewhere in the world, which have largely decreased the contact exposures which precipitate monkeypox clusters. So monkeypox present, but quieter than it had been, thank heavens. Similarly with the acute hepatitis or fulminant hepatitis of unknown etiology, although still yet the evidence would suggest that many of those patients have adeno-associated virus 2, AAV2, perhaps an important cofactor of whatever other trigger they may have. There continue to be sporadic cases, at least being diagnosed or worked on or reported. In Arizona, we've had one in the recent past, but again, those numbers are also quite low, thank heavens. Typical clinical presentation for those of you who have not heard it before is a 2 to 3 day low febrile respiratory and GI illness. Think of your typical adenovirus with a respiratory and GI component, followed then by overt onset of jaundice, scleral icterus, basically other signs of hepatic failure. In those patients who come to you with a couple-day history of viral prodrome, then have some degree of concern for liver dysfunction, low threshold to send liver testing, liver panel patients as well, and coordinate with your local county health department and also infectious diseases or GI or hepatology, depending on what resource you may have available to you in your practice area. that is pretty much it for the current things I have talked about and have mentioned as a potential hot topic coming up. The polio cluster in New York, state of, and city of, unfortunately, and also measles, which is always a risk as we continue to experience parts of this state, parts of our counties, parts of the country for sure, that have decreasing vaccine coverage for measles, mumps, and rubella. Absolutely, those potentials are out there. And so have a very low threshold to contact, again, your county health department and or infectious disease specialist if you have a suspect case for any of those. So with that, thank you for listening again to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP chapter would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, keep fighting the good fight, keep hanging in there. Send me your questions, send me your stories. If you've had specific experiences with COVID outcomes and repercussions or other infectious diseases or vaccine preventable diseases, let us know as well. This is your forum, and I'm here to hopefully bring it to everybody's ears so we can all benefit from the experiences of everybody else. So, hang in there, everybody. Thank you all for your service. Have a great rest of the day.